All right. So I wanted to welcome everybody to the inaugural Immunotherapy Rendezvous, which is going to focus on harnessing the tumor microenvironment to enhance the classification of tumors. I am one of your co-hosts, Tom Marin. I am an immunologist originally and a thoracic medical oncologist, and I lead the phase 1 program at Mount Sinai Hospital in New York.
Hi, I'm Jenna Geltnane. I'm a physician scientist and pathologist in the biopharmaceutical industry. I founded the Translational Tissue Technology Lab at Genentech in 2018, which evolved in 2022 to serving as Director of Digital Pathology and Spatial Omics. I'm currently at GSK, where I support the new precision medicine organization focused on biomarker and clinical development as Director of Medical, Translational, and Computational Pathology.
So these new rendezvous series are brought to you by the IUIS Immunotherapy Committee, and look forward to some exciting ones to come. Just as a teaser, the next one's going to focus on immune-mediated inflammatory diseases. Also, you may have seen these on the slides that were scrolling before this started, but before we begin, we wanted to highlight the global immunotalks, for which there was a QR code shown earlier, or you can go to globalimmunotalks.org. These are free immunology seminars on cutting-edge topics across all fields within immunology, which is obviously the most important field in medicine and science. And finally, there's also the 19th International Congress of Immunology. This is the IUIAS conference, which happens every few years. This year, it's going to be held in beautiful Vienna, Austria, from August 17th to 22nd. So register for that soon. I think the early bird special ends in a few weeks. So get over to the website and register for that. So let's get to the talks. We have two amazing speakers today, and then I think we're going to have a robust discussion afterwards. During the talks or after the talks, you can submit your questions through the portal, and then we'll bring them up with the speakers as we discuss some of the exciting data that they've presented. We have two phenomenal pioneers and leaders in the field of cancer immunology, specifically having helped us better understand the very complex three-dimensional architecture of the tumor and stromal and immune interface that we are now targeting with some of the next generation immune therapies. And I'm super excited to hear about their work and discuss how harnessing the tumor microenvironment to enhance both the classification of tumors and enable us to find biomarkers will also allow us to identify therapeutic vulnerabilities and help us improve outcomes for patients. So our first speaker doesn't require any introduction. This is Professor Wolf Friedman. He is really an expert in the study of the tumor microenvironment. He's a huge guru in the field of B-cell biology within tumors, and also understanding what tertiary lymphoid structures are doing within tumors, which is an exciting emerging field right now. He is a professor emeritus of immunology at the University of Paris. He received his MD and his PhD degree both from the University of Paris, and he was the founder and the first director of the Cordelier Research Center, which I've been to. It's an amazing research institution in Paris, where he currently runs a very robust research program focused on immune responses to tumor microenvironment and how those control clinical outcomes across many different tumor types. I think today we're going to hear some exciting data in the field of sarcoma. Dr. Friedman, I hand it off to you.
Thank you very much, Tom, and I will do the most difficult part of my talk, which will be to find a way to share my slides. Oh. Yeah, here we are. So, do you see my slides?
We do.
Very good. So thank you very much for the introduction. I'm very glad to be here. And what I will do in the half hours that I have, more or less, is not to give you a comprehensive view of the different parts of the tumor microenvironment, but to try to illustrate with our own data from others how the organization of the tumor microenvironment is important and essential to control the tumor and to respond to immunotherapy. And it will be mostly physiology and physiopathology, and I'm sure that Janice Taube will address the more practical and translational questions. So the tumor microenvironment is rich and depending on the tumors on all cells that are essential for a tumor to grow and for a tumor to be controlled. Of course, there are in red endothelial cells, fibroblasts, but also all cells of the immune and inflammatory systems, T cells, B cells, natural killer cells, myeloid suppressor cellular cells, dendritic cells, of course, who present antigen. But what I want, and I will discuss all the time now with during my talk, is that it is an organized tumor microenvironment, and that there are organizers of this tumor microenvironment that I believe are the tertiary lymphoid structures. So indeed, you have cells in the tumor center and the tumor core. You have cells of the immune system in the tumor invasive margin. And in many tumors, you have this adjacent tertiary lymphoid structures, which resemble very much secondary lymphoid organs found in the lymph nodes and reactive lymph nodes, the T cell zone, the B cell zone, and germinal center, I will come back to it, and dendritic cells that instruct T and B cells to mount, and which we think are anti-tumor immune responses. So a whole 20 years of analysis of the impact of the different cells of the tumor microenvironment on prognosis of different types of tumor have illustrated that the major cell is the T cell. And in particular, the memory CD8 T cells, which can be endowed for the CD8 T cell cytotoxic activity. And the vast majority of the tumor types here in green having a high density of CD8 T cells in the tumor center and in the invasive margin is associated with good prognosis. There are a few counterexamples that are of interest, but the general message is that it is good to have CD8 T cells into a tumor. However, immunity is a little bit more complicated than just having T cells. So people have started gradually looking at other types of cells. And for instance, the B cell. And this, on the right side of the slide, you find a summary that the group of Brad Nelson has published 2 years ago, in which they analyzed the presence of B cells, B memory, naive B cells, and plasma cells in various normal tissues. And these are also data from the literature, and they found them in lymphoid tissues, of course, but also in tumors. In many tumors have plasma cells. And the fold change between the tumoral tissue versus the normal tissue is sometimes 5 times, 3 times. So it's an important change. And if one looks on the impact on prognosis in terms of progression-free survival, overall survival, in red are the favorable prognosis. So B cells, plasma cells in many cases, and IgG producing plasma cells in particular is associated with good prognosis, whereas in most cases the presence of IgA as producing plasma cells is associated with poor prognosis. So where are these B cells generated and where do they come from? And this brought the attention to the tertiary lymphoid structures. Right, doesn't it? So tertiary lymphoid structures come into 3 categories. Of course, these are not so cut categories as it is shown here. In fact, it is a pathway from one to the other, but it is useful to categorize them this way. TLS, which are called immature or early. I prefer the word immature because I am not sure that this early TLS will become a late TLS, that will mature. But it is an aggregate of T and B cells mostly. There may be some dendritic cells in it, but mostly it is associated with the production of IL-10, TGF-beta, and it is immunosuppressive and rather associated with tumor progression. There are what are being called by Karina Silina primary follicle-like TLS to cope with what is seen in lymph node. They have a germinal center, but this germinal center does have follicular dendritic cells which are labeled by CD21 and not CD23, and there are sites of generation of T cell immunity and low affinity antibodies with no hypersomatic mutation and the full program to get a fully mature antibody. And there are secondary follicle-like TLS, which are fully mature TLS with a germinal center, in which you have both T cell activation and the generation of plasma cells producing isotypically switched high-affinity antibodies. Both are rather associated with favorable prognosis. You will see that mature TLS are probably more associated with response to immunotherapy. Since TLS have germinal centers and B cells and plasma cells are associated with good prognosis, it infers that sites that are capable of producing IgG-producing plasma cells, that one should find antibodies produced spontaneously into tumor. And this is the elephant in the room. For many years, people, and including myself, have seen that, but have not paid too much attention. This is a work that has been published by Ziv Schulman from Rehovot, and he just labeled a series of tumors with anti-IgG antibodies. And he found a strong labeling on B-cell lymphomas, of course, because they have IgG as a surface. But when he came to solid tumors, you see renal cell carcinoma, spontaneously you have 70% of the cells that bear IgG bound to the tumor cells. It's true for urothelial carcinoma, testicular carcinoma, thyroid, ovarian, etc. There are a few exceptions, such as fibrosarcoma, as you see at the bottom, but in most cases, there is spontaneously a population of tumor cells that is labeled with IgG antibodies, at least, and probably with IgA as well, but at least with IgG antibodies. And this suggests that they have a role to play at this level. For prognosis, indeed, when I wrote a review a few years ago where I scoped which cells or structure are associated with good prognosis in various cancer, and green CD8 T cells were associated, tertiary lymphoid structures. Treg was more disputed. Macrophages as rather in red of bad prognosis, particularly so-called M2 macrophages. And when I wrote this review in 2017, I didn't even think of B cells at that time. You see it was absent here and in the antibody. Now let's come to the second part, which is the response to immunotherapy. In the response to immunotherapy, what has really changed completely the field, as you know, is the discovery and the use of immune checkpoint molecules and antibodies to immune checkpoint molecules that has resulted in the Nobel Prize awarded to Jim Allison and Tatsuko Honjo. I always have this little image here of Pierre Goldstein, who is, in fact, he works in Marseille, in France, and he is the person, the scientist who discovered CTLA-4. He was doing differential expression banks between genes in cytotoxic lymphocyte with activated versus non-activated genes, and he described CTLA-1, 2, 3, 4, 5, etc. Two became famous. CTLA-4 kept his name, and CTLA-8 is interleukin 70. But the one who really deciphered the function of CTLA-4 doing basic immunology was Jim Allison, and Tatsuko Honjo discovered and established the function of PD-1, analyzing in thymus programmed cell death receptor in thymus, how T cell death was being induced. So in all cases, these were not immuno-oncologists, but basic immunologists working on co-stimulatory molecules for Jim Allison, on CTL cytotoxicity for Pierre Goldstein, and on T cell maturation and into the thymus. So you all know what they are. So when the T cell is activated by an antigen-presenting cell or sees a tumor cells, this activation requires co-stimulatory molecule CD28 and induces CTLA-4, which binds to the same ligand with higher affinity and regulates the system. Also, it has PD-1, which induces through interferon gamma production by the T cells is ligands PD-L1 or 2, basically PD-L1, also as an inhibitory signal. And when you come either with anti-CTLA-4 or anti-PD-1 or PD-L1, and you interrupt this inhibitory pathway, you reinvigorate the T cell that allows to control the tumors. And this has really changed the paradigm of cancer treatment, from targeting the tumor cells to targeting the immune system. So what is important, and how does the tumor microenvironment play a role in that? So I show you a few examples. Of course, as I told you at the beginning, CD8 T cells are essential. And this is a classic paper by Tony Ribas and his group in melanomas that have been treated with anti-PD-1 antibody. And he looked at the tumor, what was important for the treatment. And what he found that what was important is to have CD8 T cells, which makes sense, they are the target. But not only to have them there, you see on the left side before treatment, but they enter into the tumor. So there is a movement in the tumor microenvironment to control the tumor cells. In non-responding patients, which progress, you almost have no CD8 T cells. And of course, when you don't have them, even after treatment, they don't come. So CD8 T cells are essential. But not only, and there were in 2023 papers coming in the same issue of Nature, one from ourselves in sarcoma, one from MD Anderson in melanoma and renal cell cancer, and one from Joran Johnson in melanoma as well. All three said the same thing. In addition to the CD8 T cells, the tertiary lymphoid structure and the B cells are also essential in response to immunotherapy. And 1 year later, there was another publication in which Lucille van der Secke and Antoine Italiano in Bordeaux analyzed the impact of mature tertiary lymphoid structures that I have told you before about as a predictive factor to response to anti-PD-1 or PD-L1 blockade. So I show you the data on one slide. Altogether, there were 540 tumors, 80 different tumors histology. Mature TLS were defined by the presence of CD23 follicular dendritic cells. You see in the discovery cohort, and here there were lung and kidney and sarcoma, different types of tumor. When they had no TLS, the response rate was about 20%. Immature TLS, it didn't change. Mature TLS, it did double, and this was seen on PFS and OS, and as well as the overall survival of 2 years. And there were 2 additional independent cohorts which showed exactly the same thing, with doubling or tripling the response rate of mature when there were mature TLS. So how is it? I don't know if Yanis Taube will address this question. TLS can be detected in their maturity either easily by histopathology examination or by CD3 that can be complemented by CD3, CD20 labeling. And if wants to make a fine analysis with it, immunofluorescence, multiplex immunofluorescence with anti-CD4, CD8, CD20 for the B cell, 21 and 23. This is a fully mature TLS. You see the T cells are around, the B cells are in the middle, and you have the network of molecular genetic cells that present antigen antibody complexes to B cells. So if it is present that, does it control, organize the tumor microenvironment? And what we did is to analyze that with using the Visium technology. We did others, but we started with that, in which we have 5,000 barcoded spots, and we have 3' sequencing RNA, so we know which RNA is associated with which part in the tumor. In renal cell cancer that we studied in our first study, this is the work of Maxime Mélan. This is a tumor with no TLS. And you see we, as a marker of the tumor, we use the expression of CA9. When there's no TLS in the tumor, there is no B cell. But you have the other cells in many tumors, T cells, CD8 T cells, myeloid cells, fibroblasts, but it is an unorganized tumor microenvironment. There is no director to make it in different parts. But when you have TLS, which is seen here, you see that the B cells, now it's organized, are enriched in TLS and found outside. First of all, you have B cells, and they are organized. T cells are organized inside the TLS and found outside. CD8 T cells, LK cells are around in the tumor, as well as myeloid cells. The fibroblasts follow the TLS and are also found outside. Since B cells are in the TLS, what type of B cells are they present? Very few naive B cells, mostly memory B cells, germinal center B cells, this is what defines the mature TLS. Plasmablasts are confined to TLS, but plasma cells are present both in TLS and outside TLS. Since plasma cells produce IgG, and plasmablasts as well, what type, if we now reveals pan-Ig gene expression, it is enriched in TLS and found outside. IgM, pre-switched immunoglobulins are confined to TLS, but IgG1 and IgA are enriched in TLS and found outside, suggesting that there is a isotype switching going on into the TLS, and I will come back to it in a moment. First of all, before the isotype switching, is there a selection and an amplification which is gone, which occurs in TLS? And here again, we are in renal cell cancer. These are the number of heavy chain clonotypes found in TLS-rich versus TLS-poor tumors. And as you can see here, you have many more clonotypes when you have TLS, and in yellow are when you find more than 100 times the same clonotype, and you see that you have not only a selection, but also an amplification of certain clonotypes into when in the presence of TLS, and this is be extended to a larger cohort. Not only is there amplification and selection, but also isotypic switching. And student Guilhem Pupier analyzed that in the lab in renal cell cancer. In green are TLS-rich tumors are compared to TLS-negative tumors. And as you can see, you have more in the TLS-positive tumors of all other types, except IgD and IgE. You have more IgG3, IgG1, IgA, IgG2, IgG4, IgA2. So there is an amplification and a switching which is going on. But it doesn't tell us that it is indeed the same clone that has switched. So what Guilhem Pupier did is that he analyzed the clonotypes that are shared. For instance, each of these bars represent one tumor. In pink, it is another type that you found both on an IgM and an IgG1, for instance. Here an IgM and an IgG3. Here an IgG1 and an IgA. So this shows that indeed there has been a switching going from IgM to IgG to IgA coming, which takes place into tertiary infrastructure. Once they have switched these different clonotypes, this is the same clonotype with different isotype, travel into the tumor. From the TLS, which is present here and here, you see that you have here IgG1, IgG2, IgG3, IgG3 here, IgG4, IgG1, IgG2. I will not show you all, but IgA also goes into certain routes and IgG2 other routes. And since these antibodies that they produce have different functions, it infers that there will be different impacts on tumor cells in different parts of the tumor, and it brings us to intratumoral heterogeneity that I will tackle in a moment. Not only is it a matter of gene expression, but we analyzed also, this is a TLS, and we labeled the plasma cells by MEM1, IgG or IgA, IgG in red and IgA in green. And we found that leaving the TLS, you see, as this is a magnification, you have IgG and IgA producing plasma cells. In a higher magnification, this is embedded into fibroblastic conducts that produce CXCL12, like what is seen in the bone marrow. At distance of the TLS, here is a fibroblast conduct again that seems empty, but if you look inside it, you will see that you have a lot of plasma cells in white that are embedded into fibers that produce CXCL12. So the plasma cells do travel into the tumor. To conclude that, when you have a TLS in green, there is a lot of IgG positive plasma cells, many more than when you don't have TLS. This is true also for IgA, but at a much lower level. But most importantly, when you have IgG producing plasma cells, the tumor cells are decorated with IgG antibodies. CA9 labels in green the tumor cells, red is anti-IgG, and you see the co-labeling here. This tumor is almost 80% positive. No TLS, no plasma cells producing IgG, no antibodies being produced. And when you have TLS and IgG positive tumor cells, there is an induction of apoptosis, which is measured here by cleaved caspase-3. And this is probably due to macrophages, because here, for instance, or here, you see a dying cell in white surrounded with IgG antibodies, and macrophages in green are bound to it. We did not find NK cells. We found macrophages mostly associated to that. It has an impact of the response to immunotherapy. We separated the cohort and our patients which have been treated either as anti-PD-1 plus CTLA-4 or anti-PD-1 alone into tumors with low labeling with IgG antibodies, less than the median. This is here 60%, the mean, sorry, and more than that. So when you have a high labeling, spontaneous presence of IgG antibody, the response rate was 62% versus 18% with a low labeling, with a strong, significant difference in progression-free survival. And this is all true when the anti-PD-1 treated patients were added to it. And with that type of things, we wish to propose, and we propose that in addition to the Mellman's cancer immunity cycles that would take place into the lymph node, draining lymph node, there is an organizer inside the tumor itself, which is the tertiary lymphoid structure. When you have that, in which you have a T cell zone where mature dendritic cells present antigens to T cells. I have focused my talk mostly on B cells, but the same could have been told with clonotype, selection, amplification, etc. on T cells, and a B cell zone, which can go up to a mature plasma cell, which produces IgG antibodies, bind to tumor cells. And the tumor cells, there is some level of killing of the tumor cells, which is probably macrophage, but could be NK cell, and why not macrophage, ADCP, or complement dependent. This will induce the release of intracellular or surface tumor antigens, self-antigens, which mutated epitopes that we've taken by the antigen antibody complexes or directly go into niches taken up by B cells or myeloid cells, dendritic cells, which presents them in a very efficient fashion because these intracellular are T cell epitopes often to T cells. And together, these antigen antibody complexes would travel back to a TLS, be presented to B cell, to be by follicular dendritic cell, and contain this formidable amplification loop for checkpoint inhibition, which now can act at different level at the level of the tumor itself, but also in the niches in augmenting the T cell response to these T cell specific antigens are presented here, or augmenting the activation into TLS. Now, a few words on sarcoma, because I wanted to show you another part of tumor heterogeneity. So, as I told you, we published a few years ago a immune classification of sarcoma, which are rare disease, which was considered resistant to immunotherapy until our work and that of others. And we classified them in immune poor groups independently of their histological classification in blue, vasculature high group or immune rich group, particularly sarcoma immune class E, which is very rich in all signatures, T cells, CD8 T cells, particularly B cells, and also has a strong TLS signature. So what we did in collaboration with Usain Toby and at MD Anderson is that we got access to SARC-028, in which the patients have been treated with advanced soft tissue sarcoma with pembrolizumab. And what we found is that there was a quite impressive level of response to this treatment, depending on this sarcoma immune class where you belong. Immune poor classes, 0% responders. Immune rich class, 50% responders, which was for metastatic sarcoma was really a breakthrough. And the intermediate classes were in between. And what's characterized the immune rich class, SIG-E, was the presence of tertiary infrastructure. We found one outside, but most tertiary infrastructure was there. So I have no time to go into the details, but then Antoine Italiano did a prospective trial in which all patients with soft tissue sarcoma were selected on the presence of TLS, and they showed 33% response rate at the metastatic status, whereas there was 5% only response rate when there was no TLS. But what I want to, in the last 2 minutes, focus on is on liposarcoma. And in our work, and to get a completely independent cohort of Usain Toby, what he looked at, and this is seen in red, he didn't look at that, but I highlighted it here. You see in red are dedifferentiated liposarcoma. And these dedifferentiated liposarcoma are in the gray zone for response to pembrolizumab, anti-PD-1. They are not very bad, but they don't respond very well, although some of them have TLS. So why is it so? And soft tissue liposarcoma is very interesting in this respect. It comes into different brands. You can have some of them which are well-differentiated liposarcoma, looking very well like the adipocyte, very close to the adipocyte. These are of good prognosis. You have pure high-grade dedifferentiated liposarcomas with a lot of mitosis. You don't see the adipocytes anymore, and they are really completely dedifferentiated. And you have intermediate low-grade dedifferentiated region with still some level of adipocytes and mixed regions. What is interesting is that in the same tumor, you have all of that. In some tumors, you can have both highly differentiated zones, poorly differentiated zones, low-grade, high-grade, and mixed zones. when we looked at the impact of the presence of low-grade area versus high-grade area, having low-grade areas of good prognosis on the right side versus when you don't have them. But also, if you look at the presence or absence of TLS as expected, having TLS is of better prognosis and not having TLS because of all what I have told you. What is the relationship between both? So when we analyze the distribution of the tertiary infrastructures into the different zones. On the left side, this is a highly differentiated zone, and you see it is a completely desertic region. This is a mixed zone, and with the low-grade differentiation, and you see the tertiary infrastructures, they really are all around here. There is no cells that penetrate inside, and this is a highly protected zone by the tumor itself. So it makes sense to imagine if you treat with anti-checkpoint blockade, you may select, and we are analyzing that, some zones that will be highly resistant to the treatment. So we analyze that, and I will finish on that again by H2 Visium, and we show this is a capture zone. You see the high-grade zone is completely empty. It has almost no T cells, B cells, whatever, and the tertiary infrastructures are around that. In gene expression, you can see that you have beautiful, there is no labeling here. It's just gene expression here. You see that you can detect the follicular dendritic cells here, the germinal center, the T cell zone is around. You don't need any labeling to do that. You just have gene expression, and you see this is close to the adipocyte and doesn't enter into the barrier, which is here, formed by fibroblasts, and doesn't enter into the highly differentiated zone. So we study that and finish on that. We, in collaboration with Sarah Watson and Nadège Griel at Institut Curie, they have single-cell analysis on different sarcoma. These are signatures specific for high-grade, signatures specific for low-grade. And so we have genes that are associated with high grade and low grade. It is not in the scope of this talk, but some of these genes in the high grade are really fostering a desertic immune micro, an exclusion of the immune system. Some of the genes in the low grade are attracting B cells, attracting TLS, helping to form TLS. And therefore, we may have no new targets to target my immunotherapy. So this is what I wanted to tell you, and just want to thank very rapidly, because I have used their work to give my talk: Maxime Mélan, Guilhem Pupier, Florent Petitpré, Etienne Bech, Theo Bouloudani, and the lab, Isaias Hernandez, Anne Calvez, and Catherine Sotes-Freeman greatly contributed to the work, and this is the I was highly collaborative project with bioinformatician Antoine Italiano on sarcoma, Stéphane Houdard, Jan Alexander Vano on the renal cell cancer, Sarah Watson, and now Camilla Engblom in Karolinska for the analysis of the chronotypes of immunoglobulin. And I thank you for your attention.
Well, that was a phenomenal talk. We are going to take questions for each of the speakers right after their talks, and then we'll have a larger discussion afterwards. So if anybody has any burning questions, you can put them into the portal, and we will try to get to as many questions as possible. I also wanted to welcome Professor Miriam Rad, who is the fearless leader and the president of IUIS currently. It's always nice to have an intelligent person as a president. And so she's here to give us her
of any organization, you mean?
Just not talking about politics.
Of any organization.
Well, I'm gonna kick it off. I just wanted to ask, you showed really nicely this correlation with IgG coding the tumor cells, really correlating with response to checkpoint blockade, and you also showed, differential expression. I don't know if it was within the same tumor or in different areas of different subclasses. Is there a correlation of certain subclasses, IgG1 versus IgG4 in response to checkpoint blockade? Because you obviously have different. Well, similarly, you mentioned potentially like a role for complement. Do we see those correlations, or is there just lots of heterogeneity? So it's hard to.
So we are just beginning to do that, and we are analyzing IgA versus IgG1, 2, 3, 4, and it is interesting that we first of all, they follow different routes, which adds to the, and I have no time to show it, to the heterogeneity of the immune reaction. But secondly, usually IgA is rather associated with non-response when it is present there. IgG4, surprisingly, I would have expected that it would be associated with non-response, but it is associated with response as IgG1. IgG3 as well. So the IgGs are rather in general of good impact. When we analyze complement, and complement is not an effector molecule on cancer cells. And when you look at cancer cells, they are full of complement inhibitors on them. And if something, we found complement rather be associated with bad prognosis and non-response, but for C1q is being produced by immunosuppressive macrophages, for instance. And C3, C4 can be produced by the tumor cells and entertain, modulate the vasculature, modulate inflammation, make C3a anaphylatoxin. So all of that, we have rather the impressions that it is not good to have complement levels into a tumor. As regards NK cells, we did very stringent analysis of proximity between IgG covered dying cells, macrophages, and NK cells. NK cells are not there. The macrophages are there. CD8 T cells are not there either. I have taken it out at the last minute, not to take too much time. But I have a beautiful figure in which you have the dying tumor cells, the IgG on it, the macrophage. You look around, there are no CD8 T cell which is present there. It's somewhere else. They do something else, but not associated with that. So I think that it is more the dual, so it can be ADCC, ADCP, and in this C3 could play a role, the dual function of the macrophages, depending on what type of stimulators that they will find in the tumor microenvironment, will make them strong effector cells when IgG are being present on the tumor cells, or immunosuppressive or inflammatory, pro-inflammatory cells, modulating angiogenesis and whatever, particularly when there are no IgG present on the tumor cells.
Fascinating. Professor Murad, you have your hand up.
Yeah, well, this is extraordinary amount of work, really. So congratulations really to you and your team, because well, it's really a novel way of thinking about the TME that we have not really measured. And this particularly, I think what you are, this discussion on macrophage potentially playing a role in clearing tumor cells. This is what you are saying, but also potentially also preventing, no? So you don't think they are eating and presenting here?
Yeah, do you mean presenting antigens? Yeah. I don't hear you. I see you move your lips, but I don't hear you.
Ah, sorry. Yeah. But did you hear the first part of macrophage?
If macrophages can be also play a role at antigen presenting cells.
Yeah. So I have two questions for you. So one, can they present? Second, we see a lot of naive T cells in these TLS, especially in our human studies. That we've looked at these what we call, well, this lymphoid aggregate, we call them cellular triad. We should have called them potentially differently, but we see a lot of naive T cells accumulating there. So my question to you would be, do you think there is an attempt to prime locally, or you think there is mostly reactivation of T cells that have been primed in the lymph node? Do you think T cells really are not really playing a big role? I mean, the big role of the TLS is not really to educate T cells, but maybe to use this ADCP as we just described, which will be really novel. And if, you know, we could think about models to really study this a little bit in more detail, at the basic level. And then my first part is, do you think T cells play a role at all, or you think it's mostly antibody? And then a question that I have from my colleagues always is it a cause or consequences? Do we need to are the TLS and I think your macrophage, macrophage potential central role here can answer. Many of my colleagues' questions is always, is it a cause or consequences, this TLS? There are TLS because the tumor is immunogenic, there are T cells, but really inducing TLS is not so useful because they are not a big driver. And yet what you are saying is that even if we don't have tons of T cell priming, potentially those macrophage, that we could still have some type of anti-tumor effect through this T cell independent mechanism. So
it's a long series of questions. I will try to answer rapidly to each of them. Number one, yes, I think that macrophages do present antigen, and we have a paper in revision now that I hope will pass as a cut, as you know, in which we see that indeed in TLS, we analyze TLS positive responders and non-responders to checkpoint blockade. And various and renal cell and sarcoma. And one of the major differences is the antigen presentation capacity of macrophages between responders and non-responders. So clearly, and the expression of HLA-DR is something which is essential. I don't think that to go to the second part of your question, I don't think that the immune reaction mediated by the antibody will be sufficient to take care of the tumor. What I really think, and I was a T cell addict, as you know, for 20 years before rediscovering the B cell, is that these are amplification signals. The T cell is ultimately absolutely necessary to get control in the long term of the tumor cell. And you see that even when you follow what is going on with rituximab. Rituximab induces a very nice killing of CD20 positive lymphoma, but in the long run, it has the so-called vaccine effect, which induces a reaction that CD8 T cells take care of and control the lymphoma cells in the long run. So I think these are things that happened into tumors, because what the antibody does, and I am advocating that you don't need to have a tumor-specific antibody. You need to have an antibody that binds to a tumor cell. And once it is bound, and macrophages bound to the FC portion and start inducing apoptosis, you have the release of these intracellular antigens, in which some of them are pure cells, you will induce autoimmune reactions, but some of them are potential T cell epitopes. And in the niches that you have described and others, they will be taken up and presented to the T cells. And this will diminish the threshold. First of all, have a positive effect on prognosis, but also diminish the threshold necessary to activate this T cell with an anti-checkpoint antibody. So I think this is a mechanism by which it works. So are T cells important to form TLS? I would say yes. they are the first aggregates that one sees upon TLS formation around a vessel, around the eye endothelial vessel, before the B cell comes into the game. So I think they are, in some respect, part of the initiation of the tertiary lymphoid structures. And then you have what you said, inflammation and production of CXCL13 by TFH cells, by fibroblasts which are present there. B cells come in, and you form the complete immature first and mature tertiary lymphoid structure. Are these education completely taken up into the tumor, or do you need cells that have been educated somewhere else, T and B cells, and then they will form? In our hands, in the B cells, we found very naive. It's the only place where we found naive B cells, TLS, but most of the B cells are not naive. So it may be because they have become rapidly from the naive state to the memory state, or they have been educated somewhere else. But in any case, of course, you do not need a TLS to have an immune reaction. For years, as you know, people told me TLS have no interest. Look, we cure a lot of mice without inducing TLS, and I think in the paradise of heaven of mice, they will be grateful to you that you have done that to them. But when you have a TLS, it is an organizer of the tumor microenvironment. TLS are just a sign that the classical immune reaction has been overloaded. You see them in inflammatory diseases. You see them in autoimmune diseases. You see them in chronic graft rejection. So when the draining lymph node begins to be full of malignant cells and be corrupted, you need a place where you will have the immune reaction can take place. And the tertiary lymphoid structure at the site where the antigens are the sites where the signals are sites in which you will be able to do that. And once you have it, you organize all the rest of the tumor microenvironment. When you don't have TLS, I'm sure you looked at it. Although you may have had dedication of your immune reaction in the lymph node, you don't have this organization of the tumor microenvironment. It is organized when you have an adjacent TLS in it. It is organized in various parts of the tumor that control it. So it is not, I don't think that it is a primary immune reactive site, but I think that when a cancer develops and when the classical physiological ways of the immune reaction to take place begin to not be able to do it, then you have the system that reactivates, educates. I would start by reactivation before education, but once they are there and there are antigens being released, educate and organizes the tumor microenvironment. And all of this is necessary to have a strong response to immune checkpoint blockade and maybe other immunotherapies as well.
All right, I think we'll have one more question from Jenna before moving on.
Thank you so much. Terrific work. Really just exploding in the last few years, our understanding of this component of the immune response. I think one of the challenges from my perspective is translating this into the clinical setting, like potentially selecting patients for immunotherapy if they have TLS, or maybe more aggressive therapies if they don't, so that we might see responses in those patients. And we don't see TLS as often in metastatic samples. Do you think that the presence of the TLS in a larger resection sample we also often get in the primary setting is sort of a label for the responsiveness of the patient's immune system in general to form these structures?
Yeah, so I think that this is a major question. I don't know if Janice is going to address it, but indeed, TLS tells you that there is a sophisticated immune reaction going on, but it's a complex target. So using it at the marker, just as a marker, is very difficult because it's fine when we have access to primary surgery, surgical samples, and you have seen we have a lot of them. We can look at their organization, etc. That's fine. When we did the prospective trial with Antoine Italiano, in which we selected the patients on the presence of TLS, we didn't have that. So in all cases. So we need to have correlates for that. I still believe that selecting patients on the fact that you have a TLS or you have a correlate of a TLS showing that there is an ongoing immune reaction is essential. So how can you have a correlate on a biopsy? So we have two types of approach for that. We use that in the prospective, the first one in the prospective trial, which is to say, just what I showed you. When you have no TLS, you have no B cells and no levels of T cells. So if I find a certain level of B cell and of T cells that you have to define the threshold, I consider that I have missed the TLS and I include the patient. But because this is a sign that an immune reaction is going on. The other way is to use transcriptomic signatures. So we have made one in the paper that I published, Maxime Mélan, which is used worldwide for mature TLS, immunity paper 2 years ago. There's a 12-chem signature, which it takes chemokines which are involved in TLS formation. Sometimes we only use CXCL13. It's a good correlate and a simple correlate for TLS. So you can choose to be more or less sophisticated. But yes, my answer is TLS is too good, too complicated to be a marker by itself. So you need to select patients to have correlate. It may not be as perfect, but at least you will not lose chances for patients by doing that. Yeah.
Thank you so much. I think with that, we'll move on to our second speaker. I wanted to give a quick reminder to our attendees that they can submit their questions at any time from the Q&A tab in the ImmunoHub page. Go to the pencil icon. We're truly lucky to have our second speaker here, a true pioneer in innovative clinical and translational research for dermatopathology and immuno-oncology. Dr. Janice Taub joins us from Johns Hopkins University. She's internationally respected and recognized as a physician scientist with prolific research, including more than 180 publications and an astounding 70,000 citations. She's a respected leader in her field and directs multiple impactful research initiatives at Johns Hopkins, including running her own research lab, as well as serving in vital leadership roles at the Bloomberg Kimmel Institute to further research programs focused on the tumor microenvironment. We're so incredibly fortunate to have her expertise here today. And with that, I'll turn it over to you, Dr. Taub.
Thank you, Jenna. And thank you, Wolf, for that amazing lecture that you just gave. And so I'm going to riff off this theme of immunopathologic classification and give different examples, because there are tons of different attempts at this, looking at spatial or non-spatial metrics, so-called bulk analyses. There are the classifications as they relate to patient outcomes and patients that have been treated with, IO agents versus, if you will, a prognostic versus a predictive marker. Although certainly for immune markers, those Venn diagrams do overlap a lot. There's also a distinction between a pre-treatment classification and an on-treatment classification, and of course, within individual tumor types and across tumor types. Like Jenna mentioned, I am a practicing pathologist as well as a researcher. But because of my practice and running a CAP and CLIA certified lab, I have a specific interest and eye towards clinical use and not just research discovery, which I also very much enjoy. But there is a tension between the tools that we can use in research and then distilling those down to something more simple. And this is a point that was very well made just now by the exchange with Wolf and Jenna about what can be used pre-treatment diagnostics to help assign a patient to a given therapy. So this was quite a tour de force study in immunity. This was a TCGA analysis with more than 10,000 different tumors included. There was bulk RNA-seq that was a part of this. There was PCR and TCR clonotype analysis, of course, exome sequencing. There was even H&E type analysis of some of the immune infiltrates to look for the presence of lymphocytes seen on slides. The majority of this classification that they arrived at was really based on bulk RNA sequencing. And then they looked for correlates in some of the other data analyzed. And they defined a wound healing, an interferon gamma dominant and inflammatory, a lymphocyte depleted, an immunologically quiet, and a TGF beta dominant type. And you can see the various characteristics of them, macrophage to lymphocyte ratio, Th1 to Th2 ratio, etc., were some of the defining features. In terms of prognosis, the one that fared the best was the inflammatory type, shown in green. And I think what's notable about this is even though they used all of these multiple solid tumor types to define these, the proportion of these definitely differed by individual tumor type. So melanoma had some more of the inflammatory type than some other tissues, for example. If you shift then into using gene signatures, like had just been done, and ask about treatment decisions, interferon gamma is arguably the most well explored. And I think the ROC curve that is presented here is about right. So if you look at meta-analyses, your area under the curve for interferon gamma and also for PD-L1 immunohistochemistry and also for mutational density are all about the same at around 0.7. For reference, an ideal test would have an area under the curve as close to 1 as possible. And for a true companion diagnostic, you're normally aiming for hopefully an AUC of 0.8. In this study, they used the interferon gamma gene signature and the ROC curve to choose an ideal cut point, which is another way to use your ROC curve. And they then split based on that cut point between whether it was gamma high or gamma low, and whether patients received adjuvant therapy or not. And you can see, obviously, the patients that did the best were those that were interferon gamma high and received the adjuvant therapy. Those that did the worst were no adjuvant and were gamma low. So another way to classify tumors and start to make treatment decisions based on them. Again, both of those approaches are bulk, so not spatially resolved. When we were doing the comparison, and I just alluded to some of these data, we did a meta-analysis to ask the question, well, PD-L1 immunohistochemistry, gene expression profiling, tumor burden, or some of these emerging multiplex technologies, what is going to be more predictive? And in that meta-analysis, we had 55 different studies from 10 different tumor types and more than 8,000 patients. And each of these spots represents one of those individual studies, with the dot size representing, right here, this size represents 50 patients that are enrolled. And again, we then did a summary ROC curve through the different studies. And so you can either weight the studies based on study size or give each study that is individual equal weight. And what we found was that, again, those three other modalities in general had areas on the curve around 0.7 if you look between the weighted and the unweighted. But if you looked at multiplex IHC or IF, you were able to get that AUC around 0.8 or above. And really, a lot of the power from that is thought to come from the spatial analyses and the ability to look at that organization that we've been discussing. So I'll talk then about how we applied the multiplex to develop a spatial classification for patients with melanoma. So we took pretreatment specimens from 53 patients that had advanced disease, and we used 6 markers here. In addition to those 6 markers, we looked at PD-1 and PD-L1 as negative, low, mid, or high. And so if you looked at all of the potential combinations of those markers, plus those different levels of PD-1 and PD-L1, we had somewhere around, I think, 60 different combinations or cell phenotypes that you could come up with. And we looked at the densities of each of those phenotypes and their ability to predict response. And so, for example, here are the features, like a CD163 positive cell that's PD-L1 negative. And we looked at the density of that, and we associated it with patient outcome following checkpoint blockade. And so after we adjusted for multiple test correction, there were actually only 10 features that remained significant, some of which were positively associated with outcome, some of which were negatively associated with outcome. And none of these AUCs individually were spectacular. They weren't necessarily any better than some of the more standard markers that we were talking about, or bulk interferon gamma. But really the power came in when we combined the positive and the negative features. And we had an area under the curve above 0.9. When you look at the positive features and the negative features, we were able to define actually 3 different tumor microenvironments. And so our 3 different immune classifications were one that was very immune-rich, including the positive features that I mentioned, which are CD8 FOXP3 cells. You can even see the CD163 cells that are normally thought to be poor prognostic features. Here they have PD-L1 on their surface, and it's actually associated with a good outcome. You can also see tumor with PD-L1, the green on its surface, numerous CD8 cells. So that phenotype is good prognosis, TME. Then if you took the negative features, which were the high densities of tumor cells, which really is a marker of a less inflamed environment, but also high densities of these CD163 macrophages that importantly are PD-L1 negative, those really formed a poor prognostic immunotype. And the intermediate group were those that were neither particularly enriched in the good or the poor prognosis. So we had 3 different TMEs that we were able to identify using this strategy, and these had distinct patient outcomes. And so if you look at overall survival, those with the positive prognostic features, not surprisingly, did the best, right? 95% survival after 5 years. Those with negative prognostic features, of course, did the worst, and you can see the intermediate group as well. This was true for overall survival and progression-free survival. And we were able then to validate this in a completely independent cohort of patients treated at Yale with similar effect, and our AUC validated at 0.88. So these CD8 FOXP3 densities that really were associated with that good prognosis, we have now extended to other tumor types. We actually have shown that it's predictive of response to therapy in 4 different cohorts of patients treated with lung cancer, both in the neoadjuvant setting and the advanced setting, and interestingly in chemotherapy that's already been treated, so second-line chemotherapy from an old retrospective cohort. It's also predictive of immune therapy in patients with Merkel cell carcinoma, and that's just what we've done. There have been other investigators showing the predictive ability in other tumor types, colorectal carcinoma and ovarian for sure. Again, as was just discussed, TLS are really not typically seen on pre-treatment biopsies. They tend, and I'll show you some pretty multispectral pictures later, and Wolf already showed many, they can be ringed around the outside of a tumor. And when you take an incisional biopsy, there's often the potential for sampling error. What we have found is that there's a really strong correlation between the CD8 FOXP3 cell densities that we're seeing and TLS densities as well. So again, it is a sign of a very active anti-tumor immune microenvironment. So when we look at specimens for adjuvant therapy, I think it's important to note that those specimens, of course, have yet to be exposed to a therapy. So, you can think of it, of course, as another pre-treatment microenvironment, whereas in neoadjuvant immunotherapy, it is both potentially. We're able to look at how the specimen is responding. It's been exposed to therapy. We can see how the immune system is interacting with the tumor. So it is an on-treatment specimen. And yet at the same time, when you go on to make subsequent adjuvant therapy decisions, it then becomes the pre-treatment specimen. So we've certainly been a lot by doing learned a lot by doing comparisons between and among these treatment settings. And so I'm going to talk now about on treatment. And so again, this is a different form of, if you will, immunoclassification. And it's really defined by a constellation of features. And so you can see the tertiary lymphoid structures that I have labeled here right around the edge of the tumor bed. So where the tumor used to be extends out to the green line, and where the tumor is now is loosely outlined by the blue line. So you have somewhere between, a 40 or 50% regression in terms of surface area of the tumor that is here. This gives us a great opportunity to understand the mechanism of action of the drug, and also ask, what is the immunoarchitecture of this space that is supporting tumor clearance? And so what we find are features of immune activation, right? We've been talking about these, the tumor infiltrating lymphocytes, the tertiary lymphoid structures. I find the plasma cells to be a very reliable feature of regression. Sometimes we see granulomas. So none of that was particularly surprising and was anticipated. We often see cholesterol clefts that are present, as well as foamy macrophages. And these are the result of really the massive cell lysis that's taking place. All of the cell membranes are released, and macrophages come and clean them up. And when they can't do that anymore, you get these extracellular deposits of cholesterol, which is why we see those cholesterol clefts. What did surprise us was the degree of tissue repair that you can see. So similar to cutting your skin, when you get a wound healing effect, we're seeing that where tumor used to be. As the immune system resolves the tumor, what is left behind is a backdrop of proliferative fibrosis, as well as neovascularization, that are very reliable features in this setting. And what we found, and you guys can just, for those who are non-pathologists and not used to looking at H&E, I'm going to just show you a bunch of patterns. And the idea here is to really appreciate the sense of the architecture and how it's very similar across these different settings. So head and neck cancer, Merkel, vulvar carcinoma, cervical carcinoma, renal cell. These tumor types were all treated with either anti-PD-1 or PD-L1 monotherapy. And we're seeing all those same features that I just discussed, the TIL, the neovascularization, the tertiary lymphoid structures, the plasma cells, the cholesterol clefts, the foamy macrophages. And then if you look at other treatments combined with PD-1, PD-L1 checkpoint blockade. So PD-1 combined with chemotherapy, combined with chemoradiation, combined with targeted therapy, combinations of immunotherapies, again, across an extended array of tumor types. We now have more experience, as I was mentioning, in chemotherapy without immunotherapy. And we can see that some chemotherapies are specifically immunogenic and have this very defined immune response to them. You can also see similar features in a lymph node. So you can see the background rind here of normal lymph node, and over here off to the right is your residual tumor. And in between are all of these same features of regression. And so I think these commonalities are really important for us to start to say, it really doesn't matter what tissue type you're in, what tumor type you're dealing with. These are the requisite components that we see when you have effective immune clearance. And then we can start to drill down into what each player is doing, and is it, necessary versus sufficient. And just to continue to drive home the same point, the patterns look the same, not just if you're looking at primary tumors or tumors involving lymph nodes, but even far advanced disease and widely metastatic. So expanding our experience here now to talk about colorectal carcinoma, as well as cutaneous squame and nasopharyngeal carcinoma. Same constellation of features. And so importantly, how do these features associate with patient outcomes? So this is that if you take that calculation of the surface area of how much tumor is left divided by where did the tumor used to be. So we're starting if you have, either have completely cleared your tumor or you have less than 10% less, as defined by all of these immune features that we've described here. You can see this beautiful dose response curve in terms of how patients do with outcomes. In Merkel cell carcinoma, it's a rare tumor, so we didn't have the chance to look by percent residual viable tumor beyond 0 versus some tumor left behind. But again, you get a nice stratification. And then similarly here, using the same system in patients treated with neoadjuvant Nivo plus chemo. This was in a phase 3 registrational trial. You get this beautiful prediction of how patients are going to do in terms of event-free survival. And so what I think is worth noting in this discussion of immunotypes is that here in the on-treatment setting, this is an example that rather than looking at multiple discrete immunotypes, right, we have defined an immunotype that now spans tumor types and locations. We're looking at this constellation of features. And what we're doing is defining how patients are going to do based on the percentage of that immunotype that they demonstrate. So I'm about to hypothesize here. This is nothing that has been tested, but you can imagine a scenario, right, when you're looking at these Kaplan-Meier curves, where that these patients that have cleared their tumor after 1 or 2 cycles of chemoimmunotherapy, before even going to surgery, they've had a great response, and perhaps you can stop giving them drug at this point, which is a wonderful thing for them. Whereas these other patients that have a meaningful to very little degree of residual, but some residual disease, they're showing a response to tumor, but they haven't completely cleared their tumor. I think it's very easy to make a justification that these patients should continue to get therapy in the adjuvant setting. And then lastly, you have a group of patients that have shown no response to this therapy or very little response. They don't have that inciting immune response, that orchestrated TLS perhaps mediated immunoarchitecture that's going to help them clear the tumor. And these patients probably deserve the opportunity to have another therapy in the adjuvant setting, perhaps one that will incite that requisite immunoarchitecture for tumor clearance. When we talk about on treatment, one of our interests, of course, is how do these immunotypes, so how do these reads then associate with long-term patient outcomes? And so this is our one opportunity to do this. I know ctDNA is something that is very exciting in the field right now in terms of looking at responsive tumors versus non-tracking patient outcomes. When we actually looked at ctDNA clearance, radiographic response, and pathologic response most closely estimated patient outcomes. I also think that this is really important because it speaks to, again, clinical implementation and the fact that pathologic response is something that can be assessed on a $5 H&E stain slide using labs as they currently stand around the world, as opposed to having to bring up a new technology. For as much as I personally love new technologies, this is, cheaper and ready to go today and actually is performing better than some expensive tech. So just a little more on clinical implementation to wrap up. As I was just alluding to, you have to have the technology available. So if you look in pathology labs today, like a surgical pathology lab at a hospital, we do not do gene expression studies regularly. There are only a very few that I can think of that actually have platforms available to do that work. So just an example of something that is routinely done in the research sphere that would not necessarily translate very readily to everyday care. You, of course, have to show that things are standardized, and lots of things that are done in the research space are not so standardized. They're brought up in a lab using different protocols. You have to make sure that if you get tested at a hospital in France, you are just as eligible for your treatment as if you got tested for it in Baltimore. And those reproducibility studies typically require a time of maturation of the technology and familiarity in the field to actually set what those standards are. And then, unfortunately, reimbursement is really a big issue. So even if we have the technology, even if the oncologists want it, certainly unless we can get paid for doing the test, in our country, of course, it's by insurance, that is a huge barrier for bringing on any sort of characterization of the tumor immunophenotype. With all of that in mind, that again, that TCGA paper that I opened with is utterly remarkable, but in terms of day-to-day patient care, we're not going to be doing BCR clonotypes, TCR clonotypes, exome sequencing, bulk RNA-seq to be able to define something. We need to have something that is simple and readily detectable and detectable robustly. Also, the question of specimen adequacy, and I think we can again reflect back on the TLS example. Fantastic. Is a pretreatment biopsy specimen big enough to be able to detect TLSs? Probably not, but you do have specimen adequacy in other areas, and I'll give you a demonstration of that. And then Wolf also brought up this great point of sample heterogeneity, and I'll touch on that before I close. So I mentioned some of these factors. These are just some of the biomarkers and modalities, if you will, for detecting them that have been suggested. The H&E stain and straight immunohistochemistry, PD-L1 or otherwise, are readily available. And most places do sequencing and can easily come up with whatever the local metric of TMB is. But gene expression profiling less familiar, and multiplex technologies are definitely not in every lab, and multimodality is a whole nother futuristic exploration for actual clinical implementation. These are some reproducibility studies for multiplex immunohistochemistry, which I have been involved in. And this is a proof of principle that what we're using today in the surgical pathology lab, shown in the blue lines, immunohistochemistry. You will get the same value if you make that immunofluorescence, and then if you combine all those 6 immunofluorescence markers together, which runs the risk of steric hindrance and other sorts of crosstalk between the floors. So each of these needs to be validated in this manner. And then we did a multi-institutional study showing that co-expression analyses, as well as density and spatial metrics, were reproducible across multiple institutions. Similarly, with regard to actually calculating that component of the % residual viable tumor in the on-treatment specimens, we're wrapping up a multi-institutional international study that was supported by SITC, and you can see a number of the tumor types that are listed here, but again, showing the robustness and the ability of pathologists around the world to be able to generate this metric in a reliable way. So this is an immunophenotype or an immunotype of pathology that can be recognized and that we can benchmark against. So the question of heterogeneity. This came up to us, especially when we started doing our multiplex, because at the time when we started it 8 years ago, you weren't really able to map a whole slide, or most people didn't. And most people were taking 5 or 10 high-powered fields. And there was the question of, are you going for hotspots, or the so-called areas of immune infiltration? Or do you want to do representative sampling? So some areas from the central of the tumor, some from the periphery, which may or may not be inflamed. And a lot of that was driven by Jerome Gallone's wonderful work in colon cancer. And we didn't know the answer of where we should be sampling from, but you could definitely imagine that as you move forward to a clinical test, having a reproducible way of selecting your fields would be really important when you go to do a clinical test. You couldn't have 5 different fields selected at one institution and analyzed than the 5 fields that were analyzed somewhere else. And which way was the best way to do this? And so as a part of one of our studies to really answer this question, we mapped the entire tumor microenvironment, which is about 100 times more than most people were taking at the time. So this was the specific example in lung cancer is 1,200 fields rather than one of those single high-powered fields. Okay. So hang with me here as I walk through this. What we're looking at, again, is this metric of the area under the curve, and that's what the heat map is showing. So over here off to the right is your AUC metric. And we're asking if you look at the densities of areas in hotspots versus, and I'm not going to show you the representative sampling. The outcome is hotspots work better. Where do I get that AUC? What is my optimal sampling? And so what we're looking at, these are the cell lineages along the left side. So I'm looking at CD8 FOXP3 negative cells. These are your classic CD4 cells. CD8 positive, FOXP3 positive cells, those also the T suppressive cells here, and then CD8 positive cells. And then whether PD-1 is negative, low, mid, or high, and the same is true for PD-L1. And so you can see actually the ideal sampling based on the area under the curve is somewhere around 25% if you're looking to find your CD8, FOXP3, PD-1 low expressors. This gives you sort of your highest area under the curve. How do I make sure that what I am sampling is the same that somebody else is going to be sampling? What we did was we defined our hotspots by acquiring the entire slide, assessing a CD8 density for each of the tiles, ranking the tiles from highest to lowest, and then we were able to pull from that and sample. So while everyone, of course, talking about heterogeneity is absolutely correct, that it is there and it is an issue. What you can do, if you're strategic about it, what I'm showing here, is use that heterogeneity to your advantage, as opposed to it being a perceived disadvantage. You can actually figure out how to make your biomarkers perform better and sample in a way that helps to overcome that general heterogeneity. And so across all the markers that we were looking at, we chose a 30% sampling strategy that was related to the hot spots. So it's not insurmountable, even though it ends up being present and in some time, of course, biologically relevant. In theory, we could have chosen a different threshold for sampling and how much of the slide we wanted to acquire our biomarker from, different sampling for each marker if there had been different levels of heterogeneity for each of them. And in terms of specimen adequacy, we've at least worked so far with our CD8 FOXP3 signature, our good, intermediate, and our poor prognosis to ask a very practical question of, let's say you have 3 core needle biopsies, which you often get for tumors, and only half of that contains tumor. Will you be able to perform this assay, or will that not be enough material? And you can see shown on the left, that's that scenario of having somewhere between 5 and 20 millimeters squared of tumor on the core biopsies. We are able then to segregate our patients into their prognostic groups, just as well on the smaller biopsies as with the larger ones. So I've certainly shared a number of different strategies for immunopathologic classification of tumors. We talked about the spatial and the non-spatial metrics. I'm a big fan of spatial because I think you obviously have that increased specificity and ability to see the actual interactions that are driving the immunity. We looked at both treated and non-treated patients and examples of pre and on treatment. And I'm particularly excited about some of these pan-tumor approaches that are moving. As we move towards diagnostics, I think the ones that are best poised to go to clinic are those that use the techniques that are currently existing in surgical pathology labs. Again, those that span multiple tumor types just from a workflow and efficiency standpoint. Those that also don't require clinicians to take a new type of sample for their analysis, and also those that are associated with driving treatment decisions. All of those sort of reach the top of the queue for what we're looking at in pathology labs for implementation. With that, I'll acknowledge a bunch of the folks in my lab as well as our funders, and a specific shout out to Alex Soleil, who's the cosmologist that I work with on the AstroPath project.
Thank you so much, Dr. Tao. I could kick off our Q&A here, potentially with a quick question just on the, I think the pan-tumor classification, that, maybe be the largest multi-site pathologic response study I've seen across so many different indications. Were there any ahas from that in terms of, the immune response in this particular cancer is quite different and we need to be aware of that?
I will say that mesothelioma was challenging to assess. That was one that came up as an outlier, if you will. I think the fundamental morphology of the tumor made it very hard to differentiate from the proliferative fibrosis, and also the way that we are doing gross specimen handling. It needed something different. In terms of the immune patterning, no, actually, I would say that the shock was really just how similar everything looked. And we have yet to really find something that is failing. We found scenarios where it's hard to, so if you have a bladder cancer specimen from somebody who just had some sort of, curettage type procedure, some of the wound healing there can be challenging to differentiate, although possible, from some of tumor regression. Like there are scenarios like that that are specifically challenging. But when we do see regression, or if you move bladder cancer into a lymph node, right, where you no longer have that morphologic mimic of the prior procedure, it is very distinct and follows the same pattern that we're seeing in all of these different tumor types. And I should say we have not done a lot in brain. And so I can't comment on brain yet. I would imagine that organization might look different, but I haven't seen enough to know.
Great, thank you so much. Thomas, should we take a question or two from the online?
Sure. Actually, well, I'm going to jump in and use co-chair priority to ask a question. You both kind of touched on this a little bit, but obviously, even if you have core biopsies, oftentimes you won't see a tertiary lymphoid structure. You won't see a lot of the characteristics we're talking about. And unfortunately, we're oftentimes getting, fine needle aspirates of these tumors. And, occasionally then we'll look at PD-L1 staining on the tumor cells, and we won't get much more out of that. And hopefully we can get some sequencing. Are there any, efforts in very scant biopsies or even in FNAs to, further study and identify patients who, let's say, have, high TLS signatures? Like if you stain just for things like CXCL13, or, conversely, is there some sort of bulk transcriptomic signature that we could get out of these super small samples to help, guide our decision making? Because, it's amazing when you have these neoadjuvant trials and you have these beautiful, huge samples to study, but it's so rare, even when we, make a lot of effort to get a lot of core biopsies pre and on treatment, for us to get high quality tissue.
I will see if Wolf wants to answer with his experience, but in general, because our focus has been on immunoarchitecture, we have not done much at all with FNAs. We have definitely done, and we're lucky, like our cytology team will do a core biopsy alongside an FNA often. And we have used those, and we've characterized the core biopsy that gets taken alongside the FNA, but I have not used the FNA material alone.
So I have no experience, vast experience with FNA. What we have done was, as I said, with small biopsies and can be done. And I was very interested by what you said on CD8 FOXP3 density as a proxy for TLS. Is this published somewhere? Because
No.
yes,
coming soon to a journal near you, hopefully. Yes, no, it's not. It's not published yet.
You send it to me, because we will have to define proxies. So, for instance, the proxies that we use, but again, you need RNA because the labeling is not very good. With CXCL13 is quite a good proxy. When you don't need to have a full transcriptome. If you have CXCL13, it's not perfect, but it's not a bad proxy. One thing that I push pathologists here to look at, in this you can do on FNA, are there IgG on the tumor cells? It's as simple as that. You do an anti-IgG labeling. So again, by itself, it's not necessary, but I like Janice's approach in which you can combine. I think what we need now, after we have done the comfortable approach to define what is important, we have to do, and this is more on the hands of the pathologists than in my hands, we have to do the targeted approach for FNA. What is the minimal association of features that we need to tell us this tumor is likely to respond to checkpoint blockade? And I think it will not be 25 features. I think, for instance, I don't know, CD3 for interferon gamma signature, CXCL13. labeling of if you do IgG, I've seen many plasma cells in Janice's presentation with an anti-IgG labeling. You label plasma cells and tumor cells. If you have a labeling of that, it means that there is an ongoing immune reaction. It doesn't mean that you have absolutely a TLS, probably you have one, but at least there is a sophisticated immune reaction which has gone up to the formation of a germinal center which is going on. So I think now that these different, we have come a little bit further, the pure, we will measure CD8 T cells and that and we'll have the enzyme. We know it's more complicated than that. Now that we know what to look at, we will be able to define what are the correlates.
I have another question on that about the proxy. Do you know whether there are some correlation between CXCL13 positive cells in the blood and what you see in the tissue? Because that would make it easier also to capture.
So we have tried to do that with many other cytokines in the blood, and the data are not very impressive. And also one of the reasons is that we look at our TLS on the primary surgical sample, and we look at the serum 3 years later when we treat the patients in which the tumor has been removed in most of the cases. Now with neoadjuvant, it might be different, but in many cases there is no tumor anymore. So,
and did you try intracellular staining, like in
sorry?
CD4? Did you try intracellular staining in CD4?
No, we just measured by ELISA. When we analyzed what was really associated with the tumor microenvironment, VEGF in the plasma seemed to be more a stronger marker, or IL-6 CRP than measuring CXCL13. So, and again, it makes also sense. It's TLS are structures which cover what, Janice, in the best cases? 3% of a tumor?
I was about to say at most 5, yeah.
At most 5, okay. So you are asking to see that in the blood. So sometimes when you have a huge TLS formation in a tumor, where some tumors we have 60 TLS on our slide, so I guess in the entire tumor you might see it. But in other tumors in which you will have 3 TLS on your slide, it might not be sufficient enough. So yes, I think that trying to find what we are trying to do in the blood, because of course we all would like to have it with a blood sample, is more to look at clonotypes of B cells and T cells than on chemokines or cytokines, but which really you need. It's what goes over your bottleneck that you see in the serum, and this needs to be a very important reaction going on. But I am open to see people who are able to do it. I see that there is a question about can the tumor microenvironment induce switch from IgG to IgA in the chat. So I want to answer this question. I find it is very important and very interesting, and the answer is yes. We have now clear evidence that if we take TLS from responders, we are overloaded by an IgG response. And from non-responders, we found strong expression of SMAD, of TGF-beta signature, and IgA is increased. So yes, I think that when a tumor begins to produce tons of TGF-beta, it does a lot of things, not only inducing IgA, but also switching from IgG to IgA. So it is this is a plastic situation, and one has to imagine the site of generation of an immune reaction, which is a TLS, that undergoes evolution until it completely involves, like as a group Johns Hopkins have shown. They are formed, they develop, they become mature, and then they disappear. Les Jaffe and Janice, remember me the name of the...
Mark Yartrin.
Exactly, who did that at Johns Hopkins. But inside this, during this evolution, the modulation of what type of immune reaction will be dominant is highly dependent of the tumor around, and of the immune reaction shapes this tumor, which defends itself, produces other mediators, etc.
And do you think, because we have ideas that IgG can fuel anti-tumor responses, and do you think IgA can be just a surrogate of this change in the microenvironment, or could it also protect the tumors?
So I think that there are two things. One, IgA is clearly the marker that there is TGF-beta, and that you have an immunosuppressive immune microenvironment. But also, IgA does not induce many effector functions. So if you have a lot of IgA on a tumor cell, it might, like the desensitizing effect when people have allergy with IgE present on the basophils or other cells, and you want to replace it with IgG. IgA and IgE may compete, and IgG, sorry, may compete for similar sites, but potentially, and may be different from tumor to tumor, and may distract an effective immune reaction. But I don't know. It is we have not seen, but we haven't seen many tumors with IgA, but we have not seen signs of apoptosis on IgA covered tumors.
Can I follow up? You had said in your talk, Wolf, something about the plasma cells. You showed sort of a fibrotic or a stromal niche, and you said the plasma cells were trafficking in there. This sort of goes back to Miriam's question. How much of B cells in the TLSs maturing into plasma cells and staying put and making antibodies there? How much is there a local activity and sort of anti-tumor response happening in the tumor? And do you think that that's more important, or is it more systemic priming and everything's happening in the draining lymph node and elsewhere?
The answer to that is I am not old enough that I would have the answer. I still need to ask kind of questions for my research to be done. So I don't know. What I do know is that when you have TLS, you have selection amplification of clones, isotype mutation, affinity maturation, which takes place, and you can show that the same clone which had been affinity matured into a TLS, because we have analyzed, I haven't shown, I showed you only clonotypes, but Guilhem has analyzed PPA clones, so families of clones, which have the same V's, the same G's, the same D's, the same CDR3 lengths, but in less than 15% mutations inside the CDR3. So this is where the mutations for affinity maturation take place. And what you can beautifully see is that you have I would say, the precursors, in quotes, in the TLS, and you have hypermutated clones from IgG or IgA, which are outside of the TLS. I show that it follows a line. I don't know. I see it inside and outside. So, and I see some on the same highway. I see several aligning. So I guess this is where there was a fibroblastic fiber. So this takes place into the TLS. What I do not know really is that if it starts from a naive cell, or if you need already some kind of commitment, something has happened in the lymph node and at distance. And these, when there is a TLS, that when they come into the tumor and enter into the high endothelial venules inside the TLS, they are reactivated to do that. But I am convinced that their sites, most do not come perfectly set to produce their antibodies. And Janice has looked at many tumors. She probably knows better. When there are no TLS, are there many plasma cells into a tumor?
Fair question. I have not looked at that connection. We look at plasma cells most often. We see them on biopsies too. And then the TLS aren't present for potential correlation. But I do think that there is a large unrecognized plasma cell population that's present in a lot of tumors.
Yeah. When we look at tumors without TLS, we find very few plasma cells being present. So it's not something that the outside world of the tumor cannot do the job completely by itself. Whereas the job is completely done in-house with the TLS, or whether it is a hub that reactivated, this is still open. But I think that it is a necessary component of the immune reaction. In addition, once the antibody is on the tumor cell and it induces some level of apoptosis, and you have the release of these intracellular, mostly, antigens, they are taken up into the immune hubs that are present there. It may be the TLS, the extrafollicular sites or hubs. You don't see the dendritic cells close to that goes and brings it to the lymph node. You see the dendritic, you know better than I, you worked on it, the dendritic cells in these hubs where it presents, it does something to the system. So I do not say that there is no priming outside of the tumor, of course, but I say that the tumor is an immune organ by itself, in which at least reactivation, entertainment, an organization of the landscape of the tumor microenvironment, which is so essential. We all know that immunology is a matter of interaction between cells. So if you have an organizer of these interactions in the tumor, it will be much more efficient than if it is done elsewhere. And then it comes there and it plays it. That's why I think it is associated with better prognosis and better response. Maybe not so much because it is a place where tumor-specific responses are the only place where they're made, but because they have this complex role of organizing, reactivating, keeping the immune reaction hot and making it work. When you look, and also Janice referred to it, when you look at these tumors in which the TLSs are all around, they do not enter. It's not just stochastic organization. You have inflammation, you have TLS. No, you have an organization, a tumor say, oh, these guys are dangerous. They have to keep them outside. I don't want them to enter. So all of this, I think, speak to it. And the part of each will be dependent of, is the lymph node invaded by malignant cells? Is it not? Are we at the beginning of a tumor where it's still active? Is it already corrupted, etc., etc.? And it will depend from each situation.
I have, I guess, sort of a tangential off that, but we've had a few questions from the audience about how a lot of this work applies to different tumor types. And Janice, maybe you can start on this one, because you showed very nicely, very similar pathologic response patterns to checkpoint blockade in tumors sort of across the hot or cold spectrum, if you will. But how much at baseline how much similarity do we see between tumors? Are we seeing, you know, somebody asked specifically about ovarian cancer, if there's tertiary lymphoid structures there. Do you see, you know, based on in breast cancer, based on aggressiveness, do you see certain characteristics similar? You know, Wolf, you had shown the high grade and low grade had differential organization of TLSs. Janice, when you were looking at the pre-treatment, obviously you're looking at biopsies pre-treatment, but you also are looking at untreated specimens. How similar is this across tumor types, and can we move, you know, away from diagnosing breast cancer and lung cancer towards diagnosing TLS cancer and TLS-free cancer?
That was one of the pieces that I really liked about that first immunity paper that I presented with the TCGA piece. And I think that's fair. I think there probably are distinct histopathologic phenotypes that we'll be able to refine and describe. And yes, you know, TLS or plasma cells we've been talking about, or TIL, you know, all of these different components that we can even simply see on H&E, or perhaps with some sort of diagnostic adjunct defined. And we are able to see those across different solid tumor types. What I also think is accurate about that immunity paper is that the proportion is going to vary. So melanoma and renal, which are known to be immunoactive, often will even show a proportion of cases that have spontaneous immune-mediated regression, 5% on average. What was interesting to me about the Checkmate 816 clinical trial, I presented the on-treatment data here, but we also looked at the pre-treatment specimens. And in fact, there were singular lung cancer cases that had spontaneous immune clearance too. So I do think that these phenotypes do cross tumor type boundaries. And yes, I've seen some ovarian cancers that have TLS in them. It just happens to not be as prevalent as some other tumor types.
Terrific, thanks. I can ask another question from our audience, which I will rephrase a bit. One of the questions that's coming up is, I think about some of the rare immune cell types you're seeing in your research. And so maybe I'll phrase it like this. While we can study rare immune cells and detect them using similar innovative methods, just like we do the common ones, what is the actual influence of these in terms of them being very low numbers and scarce cells? So can these few numbers modulate the TME?
Yeah, I think it probably depends on the cell type. And I think we know from dendritic cells that they can actually modulate the TME even when they are in incredibly low numbers. I think a counterpoint to that will be the CD8 FOXP3 cell that that we're interested in and have been characterizing. On average, that's somewhere around 1 to 2% of all CD8 cells that are there. And we actually asked this question, like, is this a supercell, if you will? Do we think that this very rare cell type is really modulating this immune response and clearing the cancer? And so we actually did a very sophisticated modeling. I shouldn't say we, Heshi Raskas in our group did, who is a particle physicist. And what he did was he took the tumor and immune maps that we had generated and looked for all of the CD8 FOXP3 cells and identified the ring of cells surrounding the CD8 FOXP3 cell, that immediate tumor microenvironment. And then we took out the CD8 FOXP3 cell and went just looking for that donut, if you will, all of the contact neighbors. And essentially what we found was that immediate tumor microenvironment is equivalent at predicting how patients are going to do to the CD8 FOXP3 cell. And with some other in vitro studies and work that's ongoing, we think that the FOXP3 expression is really a transient marker of, a very activated T cell state. It also happens to be CXCL13 positive, as well as some other granzyme expression. But it is really, I think, just a stigmata of a larger tumor microenvironment. So I think that is a rare cell type that probably is not defining individually the TME, yet it's just a signal of everything else working well.
Thank you so much. Dr. Friedman, do you have anything to add to the question?
No, I was also thinking of the dendritic cells, which are essential. They are low numbers, but they are essential. In fact, when Marie-Caroline Dionojor was in the lab and we started working on TLS, we always cut in the wrong part, so we didn't have full TLS in many slides. So Marie-Caroline used to count the mature dendritic cells, DCLM positive. And DCLM positive cells was enough to predict in lung cancer prognosis. So more a cell is important, less you need numbers to prove it. So mature dendritic cells, maybe follicular dendritic cells, CD8, FOXP3, TCF1 cells, things like that. Yes, I think we are going to refine from the general, it's good to have TILs, then it's good to have T cells, then it's good to have CD8 T cells, then we will come, and maybe sometime, I believe, we will tell, maybe it's not for pathology labs, although if we have good antibodies, it's good to have these 5 clonotypes for lung cancer. So when we will have that, we will be, so yes, the small is beautiful.
Thank you.
Yeah, we have 60 seconds left. So I have a tiny question that is came from the audience, which is very interesting. Are there any observations between tertiary lymphoid structures and lymph nodes that include metastases? Do lymph nodes that have metastatic disease, do you see similar architecture? Do you see TLSs within the metastasis within the lymph node? Have you seen anything here? I know
This is a major problem, and when you look at the lymph node which is metastatic, are you looking and you see a structure like that? Is it a TLS or an SLO? So since many of the samples that we had to decide for the sarcoma trial came from lymph nodes, we had to make a decision. I couldn't just make a joke about it, that they are not enough to analyze immune cells in an immune organ. So what we did is exactly that. Yes, you can see TLSs which are really adjacent. First of all, some lymph nodes are completely tumoral. So when you see TLS, so these I think there's no problem. In other cases, we take really what is invasive margin, 500 micrometers around and outside or inside the tumor. And we consider that if it is there, it is a TLS and not a reactive SLO going on in the lymph. But again, as I said several times, and Janice as well, we are at the beginning of defining. We have to still use imperfect ways and to say, okay, this is the cutoff we have chosen to say this is a TLS, but maybe it's wrong. Maybe it is an SLO which is close to that. But for the moment, and I will finish with that, I prefer to have false positives and false negative to select patients.
That's good.
Yeah.
Well, I have to run down to clinic and we're wrapped up at 2 o'clock here Eastern. So thanks to everybody who joined today, and look out for subsequent IUIS rendezvous. Like I said, the next one is going to be super exciting, focused on immune-mediated inflammatory disease. So we will see you then. Thanks, everyone.
Bye.
Thank
Very
you.
much.
Bye, Janice. Bye, Jerome. Bye.
Bye.